All right, everyone, welcome to Grand Rounds today. Those who don't know me, my name is Amar Deshpande. I'm the Vice Chair for Education. We have our second of three of our Chief Resident presented Grand Rounds. So this is an interesting case. It's interactive. So there are several opportunities for you to please have your phones out and be able to interact and provide commentary of this interesting case with a teaching point at the end. So we have two of our Chief Residents presenting today, along with some guest speakers who will be here with us as well. So thanks to them for joining us, and you'll see them as we go. Hopefully you remember this from last time as well, where we have some expert consultants come in at various points in the case to elucidate important points. So Dr. Keith and Dr. Rao will be presenting. Dr. Keith did his biomedical engineering training in Colorado and his medical degree in Arizona. Now he was a resident here and did a healthcare policy fellowship, and now is one of our VA chief residents and is becoming a gastroenterologist at MUSC starting in the summer. And Dr. Rao went to school at Emory and then went to GW for her medical degree, also a resident here, of course, and now is one of our chiefs and is going to USC for a fellowship in also gastroenterology. So two of our best chief residents will be presenting. So take it away, guys.
Thank you. Alrighty, well, it wouldn't be a typical Grand Rounds presentation if we didn't have like some sort of AV problem, so I'm hoping that we've already gotten that out of the way now. Just wanted to say thank you all for coming. Hopefully this will be exciting today. This is meant to be interactive, so please interact with us and I will forcibly interact with you. It's gonna be great. So a couple things for today, just to get started. So disclosures, we're really not that cool, so we do not have any, unfortunately. A couple session guidelines. So the case is only known fully to the moderators. That would be Sanjana and I. And we're periodically going to have discussants weigh in on their opinions for certain things. This is, like I said, an interactive format. We will have you use your phones for some polls. So please have your smartphone out and handy. And the goal is to learn from our experts approaches to diagnosis and management as this case unravels. So to go ahead and get started, we have a 42-year-old man who's presenting to walk-in clinic with 3 months of dizziness, a neuro complaint every internist's dream, I'm sure. So what questions do you have for this patient? If you guys could take out your phones and weigh in for us.
Those of us inside, you can't get QR code.
Uh-oh. You want me to try to get it for you from there?
Maybe do you want to try that one, maybe?
Oh, yeah. That's good.
Oh, good. I see participants typing. That's always a good sign that things are working. Define dizziness. Okay, I like that. You mean lightheadedness or does the room spin? Okay, any medication changes, why are you dizzy? Amazing. Whoever wrote, just out of curiosity, whoever wrote define dizziness, could you kind of explain what you mean by that and why you think that's important? Yeah, absolutely. So vertigo versus pre-syncope.
Yeah, repeat the question because the people online will be.
Oh, gotcha. So the question, like I said, was to define dizziness. The answer from one of our wonderful interns was thinking of trying to distinguish between like a vertiginous versus some sort of like pre-syncopal event, you know, questions like is the room spinning, that type of thing. I'm seeing a lot of other things on here. So all day or episodic, timing, postural, are you staying hydrated? Excellent, all excellent questions as far as working up dizziness. So to give you a couple answers to these questions here. So for our patient, timing and duration started about 3 months prior. It's associated with intermittent blurry vision. No changes with standing versus lying down. He does have periodic feelings of unsteady walking, but otherwise denies any like gross neuromotor symptoms. Doesn't have any history of trauma or infection. Functional impact, part of the reason he's coming in is it's worsening and now he's having difficulty completing his activities of daily living. He has not vomited, isn't nauseous, hasn't really tried any over-the-counter meds and hasn't really noticed anything that alleviates it and hasn't really noticed anything that aggravates it. So on further physical exam, as far as pertinent findings, so generally speaking, no acute distress, conversant A&O ×4. An HEENT exam is overall pan negative. As far as the neuro exam, doing our best as internists for our neuro exam, right? So no aphasia, no dysarthria, cranial nerves 2 through 12 are intact, strength is intact, sensation to light, touch, and vibration throughout is also intact. He has no dysmetria or intention tremor. Does have a little bit of a slow, kind of wide base gait, but has a negative Romberg. And then otherwise, physical exam findings are within normal limits. So at this point, we would like to consult our outpatient generalist, Dr. Wajner, for his input and thoughts on, this 42-year-old gentleman presenting with these findings and how he might work that out.
Okay. Good afternoon, everyone. Well, I don't know what I'm doing here. I'm not an expert in dizziness. Okay. In fact, dizziness is one of those symptoms that I want to avoid. The patient comes in dizzy, no, you're not. And the instruction that I received from Dr. Rao was make 1 or 2 slides and 3-4 minutes of speech about approach to dizziness. This is my slide. It's just one. 3-4 minutes of a speech in dizziness is kind of difficult, but I'm gonna try to summarize what I want to transmit today. Not being an expert in the topic, what has been my approach to dizziness when a patient comes and says dizziness. My first statement, and it's a little shocking probably, is that dizziness is not a medical symptom. That's my personal approach. Why? Symptom in medicine is a study, there is a science that is called semiology, that you study the symptoms and signs. Every sign or every symptom has a definition, a semiodiagnosis, and most important, has a pathophysiology or anatomical explanation for that. And dizziness per se, if you do not reclassify what the patient means by dizziness, what I found of that symptoms is that it's vague and misleading. Coincidentally, yesterday, my last patient of the day was a patient that comes with dizziness. What were the symptoms? I'm lightheaded, so lightheaded that sometimes my body is out of me. No vertigo, happening for a few years. With that expression, I cannot grab a symptom that I have a anatomical or physiology explanation behind that symptom. So that's why, even when you look in the medical literature and you're gonna find hundreds of pages on dizziness per se, if you look carefully, many of those says dizziness and vertigo, because subconsciously, I think that everyone wants to find vertigo behind dizziness because it's the only, and I think that is the only real medical symptom that we expect to find after dizziness. What other things we have on dizziness? Near syncope. But it's a weak near syncope. I would say it's a near loss of consciousness more than near syncope, because syncope is a very specific symptom in medicine with a very clear physiology behind that makes it more narrow. And the problem with dizziness is that we are not narrowing anything here. We are just expanding more and more the search for the causes. But we approach then that patient that comes with this feeling of, I'm going to pass out, I have this tunnel vision, I think, as near syncope. And then we approach to syncope and we work up as a syncope. If you look in the literature, you are going to find that dizziness is defined as vertigo or near syncope of lightheaded. The lightheaded is very non-specific for me. What I have found in my practice, and if you see as internal medicine, you see a lot of elderly patients or diabetic patients or patients with chronic debilitating medical condition, is that the anomalies or the impaired proprioceptions makes this feeling that they feel unsteady when they are walking. The visual problems also add or isolated or add also this feeling of unsteadiness is probably the most specific, that they are in a boat that they don't know where they are going to put the next step and those things as other problems. And in internal medicine, 60% of our patients have psych problems. I mean, it's not rare that we found a lot of psychogenic problems in our patient. It has been well described. Anxiety per se is one of the causes of dizziness. And lately, a lot of I don't know. When they define what they feel as dizziness, there is a lot of also background in literature level or in culture description that it makes difficult for us to understand what the patient is trying to transmit by dizziness. So, having said that, I think that the only well-described medical symptom that comes after dizziness is vertigo. And then when we have vertigo, you can open a book, vertigo is there, you have all the pathway, everything else is written then. In medical school, we learned that we divide vertigo in peripheral and central vertigo. And you have a few causes there of peripheral and central vertigo. The majority of what you face on medical practice is peripheral because include all the other symptoms. The severity of the vertigo is not an indication that is central. I would say that is probably the opposite. The vestibulitis and those things probably are more intense and more frequent and are very, very severe. Don't expect too much symptoms even when the central cause is significant in the sense of vertigo. And the most important clinical finding to differentiate between central and peripheral vertigo, in my opinion, has been finding another symptoms or signs of central nervous disease. It's rare that it comes alone. That's the most important. Even when we learn in medical school certain specific symptoms for the vertigo, for central and peripheral, the presence of other symptoms, anomalies in the gait, the stance, another cranial nerve involved, dysphagia, diplopia, dysarthria, other symptoms is the most important to differentiate between peripheral and central. And then on top of that, you know that the vertical nystagmus per se is central and the bidirectional nystagmus is central and those things. Probably the most acute and challenging question about if it is central or peripheral is the acute vestibular syndrome. And you have the HINTS test that is well described and it's very useful because in this world of technology, even the CT or even the MRI could be misleading at the beginning. So it's very important to have in the acute vestibular syndrome, the HINT exam that makes the difference between the peripheral and central with quite a good reliability. And I think that I cannot take more time, and I'm gonna pass to the next one.
Thank you so much.
Thank you, sir.
Okay. Okay, so now that we have this nice kind of framework for dizziness, we wanted to ask you guys with another word cloud, what you would do next for this patient. What types of things would you want to order?
Technically not an incorrect answer in this case.
Okay, we see vitals, EKG, BMP. Okay, so some basic labs. CT. Dix Hall Pike. Okay, interesting.
That's good.
Orthostatic vitals. Okay.
Couple people want to dig hall.
Yeah. Does somebody want to just talk a little bit more about what they're hinting at with the Dix Hall Pike maneuver? Just shout it out. BPPV. Okay, great. Okay, so in the interest of time, we did do all of these things in the ambulatory setting, but we wanted to actually show you the MRI that we got in the outpatient setting. So here, what we can see from left to right, we have T2 with flare, and then we have T1, and then we have T2 with GAD contrast on the right. And so here, what you're looking at is enhancement of the midline cerebellar vermis. And you can see that nicely in the leftmost image with the flare enhancement, also definitely on the right. And this patient also had enhancement on the left lateral ventricle, which you can see very nicely in the T2 flare image. So obviously this is concerning. This is not normal. And something I learned through doing this case was that flare is bad. So flare hyperintensity essentially is suggesting that there's edema, there's scarring. It can really be related to several different diagnoses. We think often demyelination syndromes, but it can also be related to a whole host of things. And so because of these findings, the patient was instructed to come to the ER for inpatient admission and for IV steroids, as we tend to do in these situations, and further evaluation. So when the patient arrived to the ER, like all good internists, we took a very thorough history. So just pertinent things to discuss here, their past medical history. He had a left stage 1 testicular seminoma, which was diagnosed back in 2018. He presented really honestly just with left testicular pain. They did imaging and that's how they found it. He got a left orchiectomy. They did not touch the right at all. And he had just been following up with regular surveillance visits. There was no evidence of recurrence or no concern. In terms of allergies and meds, really nothing. Family history, also nothing. Surgical history, obviously he had the seminoma resected and there were clear margins in that procedure. And then for his social history, he's originally from Cuba. He moved to the US in 2023, works in retail. He drinks about 1 to 2 alcoholic drinks weekly, no tobacco or illicit drug use, and he lives with his wife and son.
Thanks. So vitals on inpatient, so we're essentially pan-normal. Pertinent labs including CBC, CMP, CRP, ESR, and TSH were all within normal limits. For once in their lifetime, the ER did not get any further imaging. We have no pan scan to show you, unfortunately. However, based on the current findings, we did on the inpatient service decide to pursue a lumbar puncture for other causes prior to initiation of IV steroids. So our next question for y'all would be, what sort of studies would you order on a lumbar puncture? A cell count, excellent. And what might you be looking for on a cell count, now that I'm seeing that pop up quite a bit? Sure, so whether it's like a lymphocytic or neutrophilic predominant, maybe like signs and symptoms consistent with infection, opening pressure, definitely if that's elevated, that could also be consistent with some type of infection. Cytology, good. Flow cytometry, definitely this patient who has a past medical history that includes cancer might be important to see if there's some sort of new metastatic process. Absolutely. Glucose, which might also be indicative of some sort of infection. Illegal clonal bands, excellent. Who, for someone who ever put illegal clonal bands, could you maybe just, raise your hand and explain why that you would put illegal clonal bands? Yeah, Harold. Mm-hmm.
Can say like separate the alternate time symptoms.
Mm-hmm.
Time and space separation raise some concern for multiple sclerosis.
Mm-hmm.
No diagnosis required both a CSF and a simultaneous serum sound for.
Right. So definitely looking for something like demyelinating MS. Exactly. Christian, did you have something to add?
Be good with that to get neuromyelitis antibodies, which can present us with a blurred vision and often the first presentation of MS.
Yeah, absolutely. Excellent. So to move us a little bit forward here as far as the results of our LP. So the CSF studies were as follows, just to go over pertinent positives. Total protein was a little bit elevated. There was a positive IgG index with 2 illegal clonal bands. Overall, though, anybody have any thoughts on this LP as of now with an infectious and paraneoplastic panels negative, which I'll talk about in a second. But anybody that's majorly concerned about this CSF study? So I'm seeing from over here, that's what we're thinking too, is like, okay, we don't actually really know. This isn't really pointing us in a super inflammatory direction, a super infectious direction. Just for FYI, because I'm sure everyone has memorized what a paraneoplastic panel involves. So these are the actual things that are involved in a paraneoplastic panel, as well as the infection panel for the LP results. But then the question from our end is, we really don't have, a ballpark home run diagnosis based on this LP. So what are we going to do next from here? So at this point, we're obviously going to consult our friends in neurology. So I'd like to ask Dr. Jason Margalewski to come up for us. And if you could just tell us, approach, given everything you know so far, imaging and LP findings.
Of course.
You.
Oh, hello, everybody. Thank you for inviting me. So already kind of elegantly discussed the dizziness separation, but I agree that's number one. And I actually had like 4 dizziness consults today. I'm on service at Jackson. Everybody is dizzy today. One of them had a glucose of 600. Don't consult for that. Okay. No, but I think we know now from the patient's story that we're dealing with a gait disorder, not really a vertigo or a lightheadedness even, and it's been going on for a while. So I'm going to focus on the concept of kind of gait imbalance / ataxia as the highlight of what we know so far about this person. So the first step, once you think somebody has ataxia, is to determine whether it is sensory or cerebellar pathways. So any kind of connection between the cerebellum and actually all the way down to the peripheral nerves could cause ataxia. So you have to figure out where in that pathway you are. But the big distinction would be if it's sensory, like a peripheral nerve issue, or if it's cerebellar / rhombencephalon. So cerebellum, pons, medulla, where all the tracks are running. So we figure that out based on the exam. So on the neurological exam, we will help figure out where the ataxia is coming from, and that's localization. Then the next most important thing for anything in neurology is the time course. So first you localize, then you figure out how long it's been going on. So whether it's acute, subacute, or chronic, my next slide will talk a little bit more about that. And then at this point, I like to try to do pattern recognition because I think it's more useful than kind of shotgun approaching with panels, and we'll talk about that a little bit more too. But just for example, let's say you're Japanese and you had a diarrheal illness 2 weeks ago, and now you have ataxia, areflexia, and ophthalmoplegia. Anybody know what that is? Okay, whatever. That's Miller-Fisher syndrome. So it's a triad. For me, it's an easy one, not that it matters. But you wouldn't do the whole workup, right? You already had a obvious pattern recognition syndrome. You order one test, it would be a GQ1B, it comes back positive, you stop there, you treat the patient. So we try to really narrow it down a little bit based on pattern recognition. And if you can't do it based on the pattern recognition, that's when you kind of get broad and you figure out what you need to take a picture of and what kind of studies should you be doing in the CSF and the serum, and very important what antibodies you should be looking for. Kind of part of testing is genetics. So I don't think it's going to be the case here, but either way, family history, if you had a family history of ataxia, figure out if there's an adherence pattern, and then maybe from there, further testing to help figure out why the person's ataxic. And then I like to always think about treatable ones. So there's a long list of treatable causes of ataxia. And one day I'll come and talk to you for an hour about all of them. But if you want to hear about it, but just make sure you're looking for things that you can treat, because especially the genetic ataxias, you might find it and not be able to offer very much besides physical therapy, but let's just not make sure we're missing something. So time course. Acute, subacute, chronic, kind of vague where they transition from one to the next, but either way, acute minutes to days, let's say. So that's not this person, but if it was, it could have been a stroke. So that's what those first 2 pictures is: a hemorrhagic stroke, ischemic stroke in the cerebellum, could very well cause ataxia that never goes away. But his onset wasn't so acute. It doesn't sound like. It could have been an acute vestibular syndrome that was talked about. It could have been an infectious process in the cerebellum or any of the neighboring structures. It could have been a para-infectious process like Guillain-Barré or any of its kind of variants. Acute demyelination was mentioned, like MS and NMO and MOGAD. MS by now it would have gotten better on its own, honestly. When you have an MS attack, if you don't treat it, it gets better in like 2 weeks. NMO doesn't get better on its own. MOGAD might get better on its own. Always think about toxicities, especially acutely. Alcohol is actually an acute, subacute, and chronic causes of, and maybe episodic. So alcohol is always there. This person doesn't seem to drink very much. But we're in the subacute phase, so this has been going on for months. And the top of your list there, especially when you think about treatable stuff, is the autoimmune paraneoplastic etiologies. GAD65 is a common one. There are dozens and dozens and dozens of antibodies that can cause ataxia. One genetic cause that's kind of fast is an autosomal dominant prion disease. So I just like pointing that one out. It's called Gerstmann, Schausser, Schenker. So it's cerebellar predominant prion disease, very rapid developing. usually has its family history because it's autosomal dominant. You could have a tumor in your cerebellum. So that's the subacute ones. Chronic, that's really more thinking about the neurodegenerative causes or hereditary ataxias. There are hundreds of ataxias, 50 autosomal dominant, hundreds and hundreds of recessives, just as many X-linked mitochondrials. I just won't list all of them here. And then the other time course is episodic. So if it comes and goes and it's truly ataxia, there's causes for that too. So there's 8 genetic ones. They're called the episodic ataxias. There's a newly described autosomal dominant one, SCA27, that was actually discovered here like 2 years ago. The disease has always been around, the gene's new. And Casper2 is an autoimmune cause of episodic ataxia. So just think about those. So now, this is me just trying to narrow down the differential based on all that. I think we're going to be in this autoimmune paraneoplastic realm. They have encephalitis on MRI with the flare changes, and it's enhancing. It's in the location where you kind of expected it, honestly, from his exam. There were no sensory findings. He didn't have any pseudoathetosis. He just had a wide-based, slow, cautious gait. So you kind of knew it was going to be midline cerebellum from a localization standpoint. And so that's kind of where I think it is. The other things on this list, Langerhans cells, lymphoma, sarcoid, these are things I think about when I don't know what it is, and the lesions all kind of look the same, and these are just ultra rare things that the treatment's very different, and should be looked for in the ways that you can look for them. And slow infections, I'm thinking like JC virus, and you can have things that sort of look like this, especially in the setting of virus that can enhance. But what I would do next, so really think about those antibodies. So I don't like antibody panels. So the one, that neocomplete antibody panel that was ordered, doesn't have a lot of antibodies that actually cause this syndrome on it. It has things like NMDA encephalitis, which I don't think anybody thought it was, and things like anti-Yo, which doesn't cause flare changes. So you have to know what's on your panel and know if what you're looking for is there. Beyond that, body imaging, because again, if this is paraneoplastic, something can really help them with is finding that cancer. We know this guy had a seminoma in the past. I think that's potentially relevant. I would also treat empirically like you guys plan to, but I do IVIG and Solu-Medrol at the same time. But don't mess around with it, especially if it's an intraneural antibody. They don't get better with treatment basically anyway, and you have to be very aggressive and very upfront with it, and hope for the best. And again, look for the cancer so you can treat that, which would really be the underlying treatment. And that's it. If you can't figure it out from there, then repeat testing. See if the LP find something new, and if the treatment doesn't work, upgrade them. Rituximab, cyclophosphamide, those sorts of things. Thank you.
Thank you. You'll be back really soon. Okay, so hospital course progression. So he was initiated on a gram of IV methylpred, so pulse dose steroids. And then given the flare hyperintensity association with paraneoplastic syndromes, like we just heard from Dr. Margoleski, we did do a CT and both a testicular ultrasound. There was no evidence of cancer recurrence on either of those imaging studies. And then interestingly, on day 2, he developed this phantosmia where he was having this sensation of like smelling a burning substance. And so we researched that was apparently at times, I guess, associated with a temporal seizure. So we got an EEG, and there was no concern for encephalopathy or epilepsy on that. And then lastly, given his persistent ataxia and then developing lower extremity weakness, we got spinal imaging. And on the MRI L spine, there was nerve root enhancement, specifically in like the caudal area. Okay, so 3 days on pulse dose steroids, and this is our physical exam update. The patient now has a new direction changing nystagmus with a rotatory component to both the right and left side, and it's non-fatigable. And on upward gaze, he has downward nystagmus, and on downward gaze, he has no nystagmus. We also did more kind of cerebellar physical exam maneuvers, and he did have some mild dysmetria on finger, nose, finger. The ataxic wide-based unsteady gait that he presented with has now worsened. And we would like to know if you have any thoughts on these new physical exam findings. Thoughts? Are we concerned? Yes. Do we know what this nystagmus is suggesting? I'm hearing some things. Pointing towards the central etiology. Okay, so we did not know what to do with that nystagmus. We were concerned about it. And I think a lot of internists kind of have a lot of intimidation when it comes to these types of neurologic physical exam findings. So we're just gonna have Dr. Margoleski briefly talk to us again about physical exam. Welcome back.
Thank you. Took a little nap. No, so I guess just what the exam tells me, because we already kind of knew it was central. We had the cerebellar findings and everything else, but it's just getting worse, right? So when it's just gait, it's very midline cerebellum and the vermis, usually posterior vermis. Once you start getting to the eye findings, it's actually floccular nodular cerebellum. So we're just spreading, right? So we started in the middle and we're moving our way interior. Now we're moving laterally because his arms are becoming involved. So it's just whatever this process is spreading. But like was already alluded to, whenever you see central, whenever you see vertical nystagmus, it always means central. There's no peripheral causes of vertical nystagmus, except for one very, very rare caveat of episodic BPPV where it's in the wrong canal, right? So if it's in the anterior canal, this never happens. It's like less than 10% of the time you get positional vertical nystagmus. So most of the time it means that there's something going on in the flocculonodular lobe or its connections into the vestibular nuclei, and that's what causes it. And I think this is already talked about a little bit, but what you really need to look for is the associated findings. So if you have nystagmus and ataxia, truly cerebellar ataxia, that's very scary as opposed to an inner ear problem that wouldn't cause this. I think you already talked a lot about nystagmus, so I won't say much more about that. But it's just the anatomy, and for those who like anatomy, this is kind of what I've already said. So the flocculus, that's where downbeat nystagmus lives. There's other eye movements that can also be localized to which part of the cerebellum is problematic, including what causes impaired smooth pursuit, and there's something called periodic alternating nystagmus. But it just tells you where you are in the brain. So it helps me localize things. But for this patient, it just means it's getting worse. Despite treatment, the thing is spreading. And there's a website that I mentioned here, iWiki.org. If you guys like videos, it shows you every kind of eye movement disorder that you can imagine with video. And I think these are very hard things to describe, but it's a nice way to see it.
Thank you.
Yep.
Okay, so conclusion, he's getting worse. And so at this time, this is on steroids. And so there was a decision made to hold the steroids because we were concerned that maybe we were masking some sort of other pathology. And so there was a decision made, of course, we had the neurology service on board here to initiate Plex. And so we did that. And then Plex was stopped after day 3, given no clinical improvement.
Perfect. So at this point, and I think I remembered it mentioned earlier, is that if you're getting all these things, people are getting worse, and then we're still not sure what to do, is you just repeat all the testing, right? So now what we've done at this point is we've decided to pursue further LP and serum testing for specifically cerebellar degeneration. And so this is part of the cerebellar degeneration paraneoplastic workup, which I'll go through here in a second. We also pursued looking at tumor markers. I think like Sanjana had mentioned before, there was a CT abdomen pelvis, which didn't show any recurrence of disease, a testicular ultrasound, which didn't show anything. But now at this point, giving this worsening, things were really kind of, reaching in the air for answers here. So all of these tumor markers, I think everyone is pretty familiar with. For cerebellar degeneration paraneoplastic workup, so these are looking at some things that are very specific to paraneoplastic syndromes and conditions. So things like anti-TR and anti-HU are very highly associated with certain types of cancer, mainly being things like Hodgkin's lymphoma, small cell lung cancer. Kelch-like protein is associated with testicular cancers. And the reason that we, and feel free to correct me if I'm wrong, our neurology interns can, but part of the reason that we start looking for these things specifically is, like you said, the paraneoplastic panel, initially you're kind of searching for these things that maybe aren't clinically relevant. What these are is when they're positive in people, they're called high-risk antibodies, and they're associated with over a 70% chance of someone having some sort of primary or metastatic disease. So after repeating this testing, one of these actually came back positive, which was the anti-Kelch-like protein, which is associated with testicular cancers. And so then the question is kind of, where do we go from there?
So of course we got a PET CT, and we did in fact find there was an FDG avid cluster of left para-aortic lymphadenopathy measuring up to 1 centimeter. Here we have the image. It's pretty significant there. There was also nothing in the surgical bed. Does anybody want to comment on, I guess, anatomically what the relevance is that it was the left para-aortic lymphadenopathy that is lighting up here? Sorry? Yes. So the seminal was on the left side. And so this is the lymphadenopathy in terms of the origin. If we think back to like embryology, it's all related. Okay, so here's more of the hospital course progression. So we obviously have a positive PET finding now, and ideally we would like to figure out what it is and get that tissue. So when we had IR consulted for CT-guided core biopsy, they were unable to get insufficient tissue, unfortunately. They got it, and then the pathology was run, and it just wasn't enough. So then urology was consulted for getting better tissue acquisition, but they actually deferred doing the procedure because they said it wasn't indicated in the setting of having normal tumor markers. And so at this time, we are between a rock and a hard place because we don't have tissue. We have, the paraneoplastic panel that's pointing towards a diagnosis, but we don't have definitive evidence. And so the decision was made, again, we've done steroids, Plex, the decision was made to now give rituximab empirically, given the paraneoplastic findings. So at this time, we'd actually like to call Dr. Benedetto up, or we can actually even bring the microphone, whichever is easier to you. Okay, perfect. Not yet. And so Dr. Benedetto is going to talk to us kind of on what he thinks so far and the need for getting that tissue at this time.
All right, thanks very much. So you probably all kind of know what the diagnosis is here, right? It looks pretty characteristic. So a few things. Number one, the fact that tumor markers are negative doesn't mean you don't have testis cancer, right? If your tumor markers are positive, you definitely have it, but if your tumor markers are negative, you don't. So eliminating a diagnostic test based on the fact that the tumor markers were negative is not reasonable. Secondly, this patient had a history of seminoma. Seminomas don't normally make tumor markers. If they do, it's only beta HCG, and it's less than 10% of the time. So the decision about intervening based on tumor markers I don't think is appropriate. Dr. Weiss also suggested get another urologist. But a little bit about the first question that was posed is, what do I think about the rituximab? So generally, rituximab is most appropriate or most effective in disorders in which the antibody that you have is pathogenic, right? So if that antibody is attaching to a cell and then producing some problem, and you're able to block the B cell that's making the antibody, and you reduce the antibody concentration, you're going to improve the diagnosis. And it says there, if you deplete intrathecal B cells by virtue of rituximab, you can have durable remissions. The problem here is that the KLHL autoantigen is an intracytoplasmic protein, and therefore the autoantibody is not likely to be pathogenic, right? Because it's not on the surface of the cell. These peptides prime CD4 T cells, and the mechanism by which you get the neurologic damage is by the T cell effector cells producing destruction of the tumor or of the central nervous system. So this antibody that we found is really a surrogate, and it's telling us that we have this T cell process related to this particular protein, which occurs not only in the testis, but in the central nervous system. It is true that the T cell response can be stimulated by having these IgG producing cells, but the rituximab may decrease the B cells, or would decrease the B cells, but the process is the activated T cells, which you are not really directly affecting by using rituximab. And Plex is the same thing, right? You're trying to remove an antibody that's in the plasma, but the problem isn't that antibody. The problem is activated T cells in this disorder. All right. So this is a simple slide. These are 13 patients. I'm going to show you the next slide that all of this data or this disease process is relatively new. This disease was only diagnosed in 2019. This comes from the paper of which they described 13 patients. And I show you they all got steroids. Most got IVIG. And it's a little hard to know whether something worked or not. But you can see 3 of the patients got rituximab, 2 progressed. That's what the P is. 1 had stable disease. Only one patient in this whole series improved their neurologic function. Most are stable or they get worse, right? So this disorder doesn't have a curable strategy. And the best that you can do is make the diagnosis early if possible and try to stabilize the process. I'll talk a little bit more about that.
Perfect. I'm actually gonna jump in really quick
Okay,
before you do, just real fast.
Go ahead.
We like to switch things up sometimes. So, given the hospital course with the progression of this, so with these concerns, we actually did go back to our urology colleagues and ask them really, really nicely if they would please try to get a sample. So they completed a transabdominal retroperitoneal pelvic lymph node dissection with pathology significant for metastatic malignant germ cell tumor of pure seminoma origin. And so after that, this patient received both cisplatin and etoposide. And now our final diagnosis based on these things is paraneoplastic encephalomyelitis secondary to metastatic seminoma. So really quickly before I hand it back to Dr. Benedetto here, just to kind of summarize everything quickly that happened with this patient. So this was a 42-year-old male with a history of a seminoma status post-orchiectomy who came initially for 3 months of dizziness and difficulty ambulating. The MRI showed flare signal enhancement around the ventricles and cerebellum, which prompted the initial admission to the tower. The LP was performed prior to the initiation of steroids with maybe a couple illegal clonal bands and an IgG index with elevated protein, but like we had mentioned before, really nothing significant or like home run, grand slam. CT abdomen, pelvis, and testicular ultrasound were without concerning features. Patient ended up getting worse, had dysmetria, ataxia, nystagmus, steroids were held, and Plex was initiated. And then with the cerebellar degeneration paraneoplastic workup, we ended up with a positive Kelch-like protein, which then ended up with a PET scan showing these para-aortic lymph nodes, followed by a retroperitoneal lymph node dissection, revealing a malignant seminoma, then followed by cisplatin and etoposide. Just a really small, quick 2-day visit to the tower, of course. And so I'd like to give it back to Dr. Benedetto to keep kind of discussing these really interesting cases.
Okay, so this is the sentinel paper with regard to this particular disease. This was New England Journal, and you see it was in 2019. So this is a relatively new diagnosis based on the ability to find this Kelch protein. This study, so how this came about was they did something called programmable phase display, looking to find antibodies, and they were able to find the KLHL11 antibody, and they describe the patient in this paper. But then they have a lot of archival material, and they looked for patients with testis cancer and looked for this, and they were able to find 13 patients in their archival data. So in these 13 patients, they were chosen because they had testicular problems, right? There were 11 patients who had seminoma, 2 had microlithiasis and fibrosis. Microlithiasis is a pre-cancerous type of finding. And 8 of these patients had disease that was in the testis, but 3 in other sites. They were of all stages, either localized, which is stage 1, or in their abdomen 2, or disseminated 3, or they were even extragonadal. And in the majority of these patients, the diagnosis, the neurologic diagnosis was made before the diagnosis of the testicular cancer. So were you to find somebody with this, you need to search very hard for the germ cell tumor because most likely they have it. The CSF findings were very similar to what we had here, right? The protein is minimally elevated, but it is elevated. There's a small number of lymphocytes in the CSF, and usually oligoclonal bands are positive. And I listed here the MRI findings. This was all over the place, but in general, what you see are these areas of hyperintensity, and they can be in multiple places, but mostly they are in the cerebellar or in the midbrain regions. So pretty similar to what we had here. Then there was another paper. This is also from the Mayo Clinic. So the Mayo Clinic went back and they pulled out the patients who had KLHL antibodies and looked at that population. There were 39 patients, as I said here, KLHL11 is an E3 ubiquitin protein ligase inside the cell. So it facilitates ubiquitization of proteins, right? There were 39 patients that were IgG KLHL or Kelch positive. And when they looked at those, 28 of those 39 patients had rhomboencephalitis, which is basically brainstem and cerebellar inflammatory disease, which is what we have here. So this is pretty classic for this diagnosis. And there were some that had limbic and rhomboencephalitis and some that only had limbic encephalitis, although there's another disease associated with germ cell tumors that predominantly gives you limbic encephalitis, and that's anti-MAs2, right? So he didn't have that antibody. And the symptom prevalence here, as described in that article, are pretty much what our patient had, right? Ataxia is the most common thing. So these people are going to have problems with their ability to walk. Diplopia was the next, vertigo, which we talked about. We didn't hear anything about hearing loss. Did this guy say anything about? So that's actually not uncommon. And given that we understood from the year before that many of these patients will have seminoma, you should screen patients with this antibody for cancers. And the one that you're most likely to find is testicular cancer. So of this population, they screened 25 patients, 23 of them had testicular cancer, and the vast majority were seminoma, although there were 2 mixed germ cell tumors. The 64% represents the percentage of all of the patients. Obviously, it's more than 90% will have seminoma. And 7 others had testicular microlithiasis or fibrosis. So they didn't specifically have a diagnosis of cancer, but at least 80% had something wrong with their testicle, right? Let me say a few other things. So with regard to treatment, we obviously don't know the best treatment. And immunosuppression is the primary thing that we can do, which the patients got. It probably is not terribly helpful to do Plex or rituximab, but when in doubt, those are things we tried. Rituximab probably makes much more sense than Plex because you can at least attack the B cell population. It's not the immunoglobulin that's producing the problem. The immunoglobulin tells you that you have the problem. The second thing is that for most patients who have this disease, they will not get better, and some will continue to get worse. The immunosuppression needs to be continued for long periods of time. If you find the cancer, you need to treat the cancer, and in most cases, you will find the cancer. Seminoma is a highly curable disease. The strange thing here is that this occurred years after a seminoma. Most commonly, it's 6 to 12 months after a diagnosis in the small number who have it afterwards. So this is unique, and it was important to make sure the patient didn't have a second primary. So the ultrasound of the testicle being negative was an important part of the workup here, I think, because bilateral testis cancer can occur. So most of these patients don't get better, and obviously our approach needs to be how to deal with the activated T cell population. So anti-T cell therapies of some sort would be the thing that we can consider. But the damage is done. By the time we find out about it, there's loss of central nervous system cells, and they're not going to get that function back. Things like hearing loss and ataxia are pretty unlikely to improve in the patients that were, quote, improved. But the overall, approximately 50% have some stabilization of their disease. The others meaning that they don't, and they continue to progress. And the majority of these patients will be wheelchair or bound to walk with a walker because we don't have a good treatment for this disease. So this is, this is like 1 in a gazillion. Having dealt with germ cell tumors for years and years and years, I've never seen it. I may have seen one case that I didn't know about that we thought had some kind of encephalitic picture, and we couldn't find an antibody, but we didn't know about this antibody. So maybe that person had it. But this is extremely rare. But if you get this in your workup, if you do the the pan workup for all the antibodies that you can have in the central nervous system and you get this one, then look for testis cancer. Okay, thank you very much.
Awesome.
Oh, sure.
Dr. Benedetto, though, what would be the best practice in terms of follow-up? This patient was known to have a seminoma. How many years do you have to continue to follow a patient either with a known history without any neurologic symptoms to preempt the neurologic symptoms? I.e., should you get a PET scan every 2 years? Should you get antibody screened every year? Or
So I think the answer to that is no, because this is such a rare disease that it's not really a cost-effective approach to dealing with these patients. I mean, you know, I've seen lots and lots of patients with germ cell tumors. This is it pretty much. But the answer to your question about follow-up is that in general, we are dealing with late relapse testis cancer, which is any tumor that occurs after 2 years, and that's a completely different problem that we need to know about early because those patients end up with chemorefractory disease. And that's one thing to follow up on. And second, cancers for those patients. So after a period of 5 years, we follow these patients once every year. So we have the opportunity to know if they've developed something. But in this guy, you know, he could have been seen, been well, and then developed this problem. There's no way to preemptively make this diagnosis other for the patient to show up. So we wouldn't be screening for antibodies.
Thank you. Do you think he was staged appropriately to begin with?
No, yes, I think so. So this is pretty unique because germ cell tumors can occur late, but they're almost never seminomas. And it seems unlikely that he would have this for 4 years, was it?
Yeah,
Or,
2018.
2018, 7 years.
Mhm.
And that usually just doesn't happen with seminoma. So, I mean, it's striking that we found this. And it's, you know, it's also striking that we use the PET scan because normally we don't use PET scans for testis cancer,
Mhm.
although they do work for seminomas, but not so much for the alternate. I think just a unique case, bad luck. Yeah, exactly.
Awesome.
Thank you, sir. I appreciate it. Alrighty, just to wrap up for today, it would not be a lecture from the chiefs if we did not have specific learning objectives for everyone. So we're going to go over a quick review of paraneoplastic epidemiology, pathophys, talk about some indication to involve specifically specialists in the management of this and understand common treatment approaches in addition to kind of what we've already talked about. So just a couple things in general. So definition of a paraneoplastic syndrome are remote effects of malignancies not attributable to direct tumor invasion or metastases. And the pathophys is typically related to either the production of things like hormones, such as ectopic adrenocorticotropic hormone, peptides such as parathyroid hormone-related peptide, cytokines such as IL-6, which drive a lot of like thrombocytopenias and that type of thing, and then as well as immune cross-reactivity with malignant and normal tissues. So as far as epidemiology, as best as I could find, so these occur in approximately, very much approximately based on what the available data that we have in about 8% of cancer patients. The most common presenting system is some type of neuropathy, and it impacts both men and women equally. The most common cancers associated with these type of syndromes include lung cancer, specifically usually small cell lung cancer, breast cancer, hematologic malignancies, usually some sort of like Hodgkin's lymphoma, medullary thyroid cancer, Dr. Weiss's favorite, gynecologic malignancies, as well as prostate cancer. And then, so it can essentially impact any system within the body, but the most commonly affected systems are going to be the neurologic system, the integumentary system, the GI system, which is obviously our two favorite and the most important, the hematologic system, endocrine system, as well as the rheumatologic symptoms. But the most common presenting out of all of them is going to be the neurologic system. So a couple things that I want to say here. Obviously, as any good internist, we immediately went to UpToDate to do all of our research for these items. So a couple things that I want to point out, and I know this is kind of the tiny font, but these are just the most common paraneoplastic syndromes affecting the peripheral nervous or the nervous system in general. Any of the, if you see on here, any of the ones that have like the little star by them are associated with a specific type of either peptide or protein, such as like the Kelch one, as in this case. And in those cases, they're considered high risk, kind of like Dr. Benedetto was saying, that when you find them, they have an association of over 70% with a malignant cancer. So when you find these type of things, you do need to go searching for them. A couple of the main ones that are going to be most common are going to be the encephalomyelitis, like our patient had, limbic encephalitis, which impacts a little bit more of the memory system. Lambert-Eaton myasthenia gravis, which if you remember from your step 1, step 2 is when you produce autoantibodies to the acetylcholine receptors, you present with weakness. And then I'll also add in here, just because they're the most common presenting, is the neuropathy. But then the question obviously that we have as internists is, Sanjana and I might be the best internists that you guys know, and I will, fight to the death for that statement. But that being said, this is a lot of very complex, neurological findings. And so the question is when should we involve our specialists to help us with, what in the world is going on with these complex patients. So like I mentioned here, this is just, a list of the most common ones. As mentioned, there are hundreds of different, peptides, hormones, and different things. And so at the end of the day, the answer to that question is, if you're ever suspecting anything type of this, when to involve the specialist is as soon as possible, which usually I would say we're pretty good at. So a couple things as far as management strategies, I'll just touch quickly because I think Dr. Benedetto did a much more eloquent job than I ever could, but perfect. All part of addressing the underlying malignancy. Most of them are related to immune mediated. So you either want to remove the antigen or suppress the immune system with any of the options listed below. And these are our references. And that is it for today. Thank you guys so much for joining. I don't know if anyone has any questions. We have 2 minutes.
Oh.
Sure. So the question was, would you treat the patient without the biopsy given the clinical findings?
We did have a conversation about this before we got to the point of the node dissection. And since this patient had a diagnosis of testis cancer previously, I would have favored treating him without a diagnosis if we couldn't make it any other way. If it was a patient that never had the diagnosis of testis cancer, I didn't go into it, but of that 39 patients, a portion had what we would call non-perineoplastic because we couldn't find disease. And that's a different group of patients. Actually, they do worse than the population that we find the cancer, because in this case, the cancer is treatable and treating the cancer may help. So I would have treated him.
I want to thank all our expert discussants, especially our 2 chief residents who did a fantastic job finding the case, and Dr. Deshpande for mentoring them during the way. Everyone, please check the QR code in order to obtain MOC and CME credit. We'll see you all next week and have a great and safe day. Thank you.
Thank you so much for coming. We really appreciate it. Thank you.